Thank you all very much for your kind attention this afternoon, listening about epilepsy diets. I'm Dr. Eric Kossoff. I'm a professor of neurology and pediatrics. And so I will start first to talk about children and ketogenic diets. I'll speak for probably about 15 minutes with a broad overview of how we approach and use diet therapy for children, followed by my partner, who's here with me today, Dr. Mackenzie Cervenka, who will then speak for about 15 minutes about adults. Following that, as was mentioned, we will open up for questions and answers. So we will go ahead and get started. There's a lot out there, and certainly you're all here today to listen, to hear about ketogenic diet therapy. Some of the information that's out there is good. Some of it maybe not so good. There's some information out there that can be misleading, and I will, in fact, today, during my session, address some of the myths about diet therapy as we use it specifically for epilepsy. But I think it really overall has been a good thing to get information out there and to really raise awareness about a very underutilized therapy that can be incredibly powerful and helpful for, in my case, children with epilepsy. This was just about 4 years ago on the Jones Falls Expressway in Baltimore. I was stopped in traffic. I didn't take this while I was actually driving, but you can see here, here, are you ready to feel better? Text ketones to this number. Everybody's talking about ketogenic diets. And so we're going to answer some of those questions here today to really get you the true facts. So, I think before we even get into what diets are and how we use them, I think it's important to talk about why we even think about trying something other than medications. Medications are the mainstay for epilepsy. They generally are widely available. You can get them at your local pharmacy, but we know that they don't always work. About 47% in a study from 2000, and this is a study of adults, will respond to the first drug, 14% if you have to go to the second drug, but only about 1% if you have to go to a third drug. And that's where we have the definition of refractory epilepsy being failure to respond to 2 drugs at an appropriate level. But this was 2000. This was now 23 years ago. And so the same author said, maybe if we update this with some of the newer drugs that have come out over the past 2 decades, these numbers won't look as disappointing with our third medication. And so they did, and they actually did a recent review looking at the same population with the newer drugs. Really not a whole lot had changed. Maybe some less side effects, more options, more formulations, but there still is, as you can see, a sizable proportion of patients that if you have to go to a third drug, there's very low likelihood of responding. Doesn't mean we won't try, but that's usually when we start thinking about other options, including epilepsy surgery, neurostimulation, and diet therapy. The diet works very well, and so it raises the question about maybe using it sooner than after 2 drugs have failed, and we'll come back to that. But in general, what we know for pediatrics is that after about 6 months' time, this is what we see, with a little more than half of the children starting on the ketogenic diet, having at least half of their seizures improved, with about maybe 15% becoming seizure-free. We also know that there are some situations in which diet therapy is even better than that, maybe a 90% response, or even in the case of a condition listed here, 5 down, GLUT1 deficiency, you might have about a 90% seizure-free response rate. So this is a list that was in our 2018 ketogenic diet pediatric consensus guideline of conditions in which overall the average was at least 70% responder rates. And these are conditions that are sort of known on the internet, known by epileptologists and parents alike. And these children, we believe, as a ketogenic diet community, should be referred sooner rather than later, just because of how good the ketogenic diet can be for these specific situations. One of the things that we're very interested in is looking for new indications beyond that table I just showed you. One of the conditions that we are particularly interested in at Johns Hopkins is absence epilepsy. For about 100 years, we've known that ketogenic diets can be very helpful for absence epilepsy when medications have failed. And absence epilepsy is an epilepsy where children have multiple staring spells per day, sometimes hundreds per day, and they usually do outgrow it, but it can sometimes be difficult to treat. The EEG can look like, as you see here on the right, with something called 3 per second spike wave. Traditionally, children are put on ethosuximide. It actually works very well, but it has some side effects, and families sometimes ask us, could we try diet therapy first? So this is a prospective trial being done at Johns Hopkins. The clinicaltrials.gov information number is listed below. And this is a trial including children aged 3 to 12, where the families can decide to do either ethosuximide, the standard care, or a version of the diet called the modified Atkins diet. An idea that I think is really here to stay about using diets maybe earlier, and in this case, maybe even first. And so you can see about this on the internet. There are other trials being done around the country looking at diet therapy for epilepsy, where they're looking for patients to be in these trials to get care. There are, I think, some big myths out there, and I'm going to come back to these mostly near the end of my talk. But the first big myth about the diet is that it is all natural, it is holistic, it is without any side effects, and it certainly does have some risks. I think they're mostly manageable, and we'll talk about them maybe a little bit later in my talk. Second, it's similar to what I've seen in books, magazines, the internet, supermarkets, YouTube videos, and there's similarities, but for the most part, as we do it for epilepsy, it's very different. And then lastly, something that comes up a lot when I counsel families about trying the ketogenic diet for their child. Sometimes there's a perception that it's an or when it really is an and. And most of our patients, we'll talk about the data, are on both medications and the ketogenic diet. They work very well together. Sometimes we can reduce the medicines, but for the most part, it's something that's done for children who failed medications. The medicines aren't working. We'll add the diet to see if it can be helpful. There are now multiple different ketogenic diets available. That's another myth, that there is just one ketogenic diet, often referred to as the classic ketogenic diet. The second pie graph you can see here, which is about 90% fat, with most of what's left being protein. But now there's actually multiple ketogenic diets: the MCT diet, the modified Atkins diet, which was created at Hopkins, the low glycemic index treatment, and then recently a version of the modified Atkins diet called the modified ketogenic diet that has been started in the United Kingdom. So many different options for families to try. But in general, they're all still, for the most part, high fat, moderate protein, low carbohydrate diets. And this is from my dietitian, from the meal plans that she provides to children and their parents. And you can see the basic structure may include a high fat source such as cream, butter, mayonnaise, or oil. And a typical menu is weighed and measured for a classic ketogenic diet patient on a gram scale. And you can see that to the right. And these are some photographs to show you what a 2-to-1 versus a 3-to-1 versus a 4-to-1, the most strict ketogenic diet, can look like. And that is the ratio of fat in grams to carbohydrates and protein combined. The higher the ratio, the more fat and less carbohydrates. But there's lots of great options out there. These are from some cookbooks, as you can see on the left. This is actually a ketogenic diet chef making some brownies on the right. These are photographs that I've taken at different ketogenic conferences and parent support groups. It can be very appetizing. These are from some other countries, in fact, showing different ketogenic diet foods, including, as you can see here, waffles and even some foods from Asia on the right. The MAD, or the modified Atkins diet, is designed to be a little bit less restrictive without weighing and measuring foods, using a families looking at information that they can find on food labels to monitor the carbohydrates and keep the carbohydrates 20 grams or less per day. So when you look on the internet and you look in recipe books, for the most part, it probably is more similar to a modified Atkins diet than a true ketogenic diet. This was created by one of my dietitians a few years ago to show sort of what a typical week worth of food on the Atkins diet for epilepsy can look like. This was generally trying to keep the carbohydrates to 15 grams or less per day, and it's a guideline. And the nice part about the modified Atkins diet is it's not prescriptive. The families can come up with their recipes on their own. When we do bring children in for the classic ketogenic diet, we bring them in for what we call an admission week, although it really is actually only 3 days. The children come into the hospital on Monday for the education and for the initiation of the diet. And about half of the children we fast with just clear fluids, and another half we actually continue their regular foods until about 5 o'clock, when we start the ketogenic diet with half calories and then follow their blood sugars and their ketones pretty closely. Classes are an important part of our admission week. You can see in the top right a photograph of one of our classes in a conference room where we're teaching the parents about how to do the ketogenic diet. Tuesday, the foods start to arrive more in solid food form as opposed to more of a shake that's given on Monday. The parents are starting to check the ketones, and then the calories are increased. And you can see in the middle photograph sort of what a typical ketogenic diet breakfast looks like, brought on a food tray from our cafeteria. And then on Wednesday, our children finish up their courses with their parents, and they go home with their prescriptions and appointments set up, usually middle of the day on Wednesday. And this has changed over the years. It's very flexible. We may be changing this more over the next few years. We generally will see the children regularly. Usually we see them back at 1 month and then every 3 to 6 months to see how they're doing in terms of weight, height, seizure control, and we also check their lab work on a pretty regular basis. And then for the most part, we tell families, give it about 3 months. And then if it's not helping, we can come off. But if it's helping, we usually keep children on in pediatrics about 2 years. You'll hear more about adults coming up soon about that. But generally after 2 years, we will try to get the children off the ketogenic diet and see if it's no longer necessary. So at least in pediatrics, for the most part, it's not a lifelong therapy. Side effects, we said that, the diet has a perception that it's all natural and has no side effects. And, that is not completely true. There are side effects, but they are preventable. You can monitor for them. And in many cases with supplements, prevent them from happening. The more common ones tend to be GI related, constipation, reflux, acidosis, sometimes hunger. Whereas the more sporadic ones we're working on as a keto community include kidney stones, growth slowing, high cholesterol, and vitamin D deficiency. Most of these usually do not lead to stopping the diet. You can make changes to fix these. The most common reason we stop the diet is that it's just not helping the seizures. Drugs in the ketogenic diet, as I mentioned, about 80% of children are also on anti-seizure drugs. It's usually, again, an and, not an or, drugs and the diet. However, we can usually kind of try to think about coming off those drugs. We usually try to get them on a tablet formulation as opposed to a liquid formulation, which may have some carbohydrates. And there really is no one drug that's good with the diet or bad with the diet. They all have potentially some interactions and issues, but we don't tell families you have to stop one drug or you must start another drug while you're on the diet. Again, they usually do go together. Hopefully you found a lot of what I said interesting. I will turn things over to Dr. Cervenka to talk about adults. If you want more information about ketogenic diets, especially for pediatrics, the Charlie Foundation has a great website. They're based in Santa Monica, California. Matthew's Friends, based out of England, also has excellent information for families and patients considering ketogenic diet therapy. And then, of course, the Epilepsy Foundation has a large amount of information, not just about diet therapy, but also about epilepsy overall. As well, Dr. Cervenka, as well as myself, Zahava Turner and Bobby Henry Barron, our dietitians, wrote the 7th edition of our ketogenic diet book relatively recently. It's very up to date with information about the diet, how we start it, why we start it. A lot of the things that you're hearing about are covered in much more detail in this book. And as well, if you really want to dive into the scientific information about using ketogenic diets for pediatrics, this is the guideline, which was published in 2018 in Epilepsy Open. It's an open access journal, so anybody can download this document, which really gets into sort of the nitty-gritty of how we exactly start and maintain ketogenic diets. As well, we will be having a conference. We meet usually every 2 years, and our 8th Global Symposium on Ketogenic Diet Therapies will be held this September in San Diego, California. I encourage families and providers to come. There's actually a family day being held on the Saturday of the conference, and you will hear all and everything about the ketogenic diet at this meeting. And then this is our team, and with that, I will turn things over to Dr. Mackenzie Cervenka.
Hello, everyone. Thank you so much for joining us this afternoon. I am Dr. Mackenzie Cervenka. I am a professor of neurology at Johns Hopkins. I'm the medical director of the Adult Epilepsy Diet Center and the Adult Epilepsy Monitoring Unit. And today I will be talking about ketogenic diet therapies in the management of epilepsy in adults. And I always like to start by pointing out that, in fact, ketogenic diets have been used for adults for as long as they have been used in the management of epilepsy for children. And in fact, this initial article over 100 years ago described the experience of 3 patients treated with a ketogenic diet therapy, and 2 out of those 3 patients were, in fact, adults, ages 23 and 31. So if we had to look back, in fact, more adults were treated with a ketogenic diet in that initial article than children. Fast forwarding to 1930, this is an early article looking at the use of ketogenic diet in patients 16 to 51 years of age, and the diet duration was anywhere from 1 to 42 months and 56% derived benefit. Now, you just heard from Dr. Kossoff what the response rate is now to anti-seizure medications. And so you can appreciate that actually, even back in 1930, the response to a ketogenic diet was very similar to what we see today for these anti-seizure medications. You also saw this slide where Dr. Kossoff talked about these indications for diet therapy for pediatric epilepsy. And I would just like to highlight that all of these indications in red boxes here are also diagnoses where we treat adults with epilepsy. Here again, in this table, we see all of these indications for using diet therapies for children. And in fact, we treat adult patients with these types of epilepsy. And so when we think about using ketogenic diet therapies, why would we not consider using these therapies for adults who have just not been treated in the past with these therapies when they were children, or perhaps were newly diagnosed? You heard a little bit about glucose transporter type 1 deficiency syndrome, and actually this condition was only discovered in 1990. So in fact, there are adults who have yet to be diagnosed and do have glucose transporter type 1 deficiency syndrome. And we're going to be discovering that, and these patients are absolutely appropriate to be started on ketogenic diet therapies as adults. There have been a number of studies that have now been done recently looking at the use of these therapies. You've heard about several different variations on ketogenic diet therapies. The one that has been most popular in the use in adults has been the modified Atkins diet. And of course, Dr. Kossoff and his colleagues have looked at this as far back as 2008 in a series of adults over 6 months. And what they found was that in 1 month and at 3 months, 47% had a greater than 50% seizure reduction. This is what we consider a responder rate. And with a responder rate, that is actually very similar to anti-seizure medications. This was in combination with anti-seizure medications, but that is what is typical when we're looking at clinical drug trials as well. So very promising results. And at 6 months, that response was sustained in 33% of participants. Now, there have been many other studies that have come out since then looking at classic ketogenic diets, at modified Atkins diets, and other variations on these ketogenic diet therapies in adults. And one of the themes that has come from this is that about 50% of individuals will stop the diet within around 6 months of starting it, regardless of whether or not they see benefits with regards to seizure control. And so this does give us a challenge in terms of trying to think of ways that we can optimize the diet, we can provide support so that adults can maintain the diet long term. And so the conclusion to this particular review that was done several years ago was that the benefits are modest, effect is rapid. So usually if a patient has very frequent seizures, we can see benefit within the first week, and that many patients do discontinue the diet due to restrictiveness. And it's our responsibility as providers to try and help find strategies so that patients will be able to stay on the diet long term. Fortunately, there have been more recent studies that have actually compared these diets to standard of care interventions. So for instance, patients who have been on anti-seizure medications and their habitual diet versus starting one of these diet therapies, because these earlier studies in adults simply followed the same individual before they were on a diet and compared them as they had been on the diet at these various time points. And so these randomized trials have shown these diets to be of benefit over using just the anti-seizure medication and the habitual diet combined. However, these results have again been mixed. You can see this one study here showed a significant difference in response rates of 35.5% versus 0% in a control group, whereas in a different study, there was no significant difference between the two groups. However, there was a significant moderate reduction, meaning a greater than 25% reduction in seizures compared to controls. Now, looking at this information combined, a recent Cochrane review concluded that really more evidence is still needed in order to support the use of ketogenic diet therapies in adults for the management of epilepsy. Fortunately, just this year, another study recently came out, and it was a much larger study, 160 patients ages 10 to 55 years, randomized to control or the modified Atkins diet in combination with anti-seizure medicines over 6 months, 80 participants in each group. 58% completed the modified Atkins diet arm. And again, this is comparable to what we've seen in other studies. 78% completed the control study, and the responder rate was higher in the modified Atkins group compared to the control group. And one thing that I found very, very interesting about this study was that actually the adults did better than the adolescents. And so this really tells you that adults can do the diet too. Now, I say the adults can do the diet too, but the adults have decided to try and prove this on their own as well, as it turns out. So there's this whole other thing that's been going on recently, completely separate from the use of ketogenic diet therapies in epilepsy, is that ketogenic diets have actually become very popular in the management of obesity, in diabetes, in cancer, and lots of other areas. And so we've kind of collectively referred to this as the keto craze, and you can see it here in all these different magazines and articles. It started around 2017, and at least for weight loss, it's starting to sort of taper off. But because of this phenomenon of the keto craze, we really refer to it more as ketogenic diet therapy now when we're talking about it for the treatment of epilepsy. And also just to emphasize, as Dr. Kossoff was saying, that these diets are not without side effects. And so we really have to be careful when we're using them, that we're using them as a therapy and that we're using them under medical supervision. And so as part of that, a group of investigators got together and put together an group of international recommendations for ketogenic diet therapy, specifically in adults. And so we found that we had actually, by that time, treated over 2,100 adults worldwide. And we found that we were actually using mostly the modified Atkins diet, but variations on the modified Atkins diet on other ketogenic diet therapies and combinations of these therapies, so really tailored to the individual. And we weren't just using them for seizures, we were also using them for brain tumors, headaches, Alzheimer's, Parkinson's disease, inclusion body myositis, Huntington's disease, normal pressure hydrocephalus, and some providers were also using them for medical conditions such as obesity, non-neurologic malignancy, and type 2 diabetes management as well. So how do we improve the success for the diet in adults? There are lots of creative ways of doing this. Modified diets, cooking classes, there are formulas that are commercially available, ketogenic food products, websites, recipes, apps. There are all kinds of supportive things that are available. Pre-made meals that actually can be delivered to your home, and we can use telemedicine. So here is our little shot of telemedicine. So obviously you guys are here doing this, watching us do this webinar today. This is one of our examples of a question and answer session that we do with our patients, and this is our team. Here we're talking about why hydration is so very important with the diets. This is a party that we do every so often where patients will actually bring in their own food and we'll all share foods. That's actually my daughter who's eating a giant pile of ketogenic icing there, and our dietitian, Bobby, as well. So we have a whole lot of fun. And then here's the not fun part. There are, as you heard from Dr. Kossoff, the potential for lots of side effects. And so we do need to think about this. There are ways to avoid them, but we do have to take them very seriously. Vitamin mineral deficiencies, easy to avoid. You have to take vitamin supplements, vitamin D supplements, multivitamin, calcium supplements. You can avoid those. Low bone mass. This one is tricky because even if you take calcium and vitamin D supplements, this can still be a long-term risk of the diet. Kidney stones, that can be a short-term or a long-term risk of ketogenic diet therapies. High cholesterol, this is still under evaluation, as well as is there a potential risk for cardiovascular and cerebrovascular disease. So this is something that has been a hot topic in various articles recently. So artificial sweeteners, when we're talking about replacements for high carbohydrate foods, there are lots of artificial sweeteners like erythritol. There are recent studies looking at patients who are individuals who have a higher erythritol levels and possibility of higher risk of cardiovascular disease. However, these are correlational studies, and so really more research needs to be done to figure out whether this is actually placing individuals at risk for higher cardiovascular disease. Here's another study. Keto-like diet may be associated with a higher risk of heart disease. But if you drill down into the original article that's of concern, it's describing a keto-like diet where the percentage of fat is 45% and the percentage of carbohydrates is 25%, not the keto diet that we're talking about here. So more research is needed to really determine whether or not this is a concern. And so one of the researchers who's looking into this is someone here at Johns Hopkins, Dr. Tanya McDonald. She's published a number of papers, and there's ongoing research looking at particularly in adults using ketogenic diet therapies for the management of epilepsy and whether or not these concerns are valid. And so we really need more information. These studies are ongoing. And then your question may be, well, what if I'm an adult and I'm interested in ketogenic diet therapies, but I don't live near Baltimore. I'm not near Johns Hopkins. What can I do? So this is a wonderful resource. This is the Charlie Foundation. So charliefoundation.org. You can click on resources. You can click on find a hospital, and you can search and find the center near you. There are actually, it indicates which are adult centers and take care of adult patients. So in conclusion, ketogenic diet therapies have been used safely and effectively for over 1 century to treat people of all ages with epilepsy. They should be used with medical and nutrition supervision to avoid side effects and to optimize therapeutic benefit. Here is our team, funding sources, and our research collaborators. And thank you all for listening. And I think we have a lot of time to take some of your questions as well. And so we'll go ahead and do that. Thank you so much.
Right. We're obviously here together to help answer your questions. See what's coming up through the chat. Okay. First question. At what point after finding seizure freedom with keto would you recommend your patients to wean medication? So I guess we both tackle that.
Sure.
So I think, from a pediatric perspective, first of all, I think we're pretty clear in our guidelines that you don't have to be seizure free. So, we have a child who comes back to us and they are 50% better, 75% better. We may start considering medication wean. Usually we wait about a month just to kind of make sure the diet's going well, make sure they're tolerating it well, make sure that it's safe and there's no major issues that would make us want to discontinue it. So usually we try to wait a month. There are some differences where maybe a child is on multiple medicines and we start weaning their medicine right away. But usually we wait at least till the first clinic visit, which is at about a month.
So actually, my answer would be very different for an adult, because typically when we're talking about adults who are thinking about ketogenic diet therapies, they have been on anti-seizure medications for a very long time. And one of their motivations for wanting to try the diet is to be seizure-free, particularly so that they can drive. And so we wouldn't necessarily start to taper medicine until we have achieved that goal. And usually with an adult, what we would do is we would put them on the diet. we would try to obtain that seizure freedom and then maintain it for up to 2 years. Now, typically with an adult, it really depends also on what the underlying type of seizures are, because we might know that they have a seizure type where we know they're going to need to be on lifelong therapy of some kind. And so if they remain seizure-free for 2 years, then what we can consider at that point is maybe repeating an MRI, maybe repeating an EEG, and then thinking about what therapies we might want to taper. Now, there are always exceptions to that rule. Some people will come to us and they already are seizure-free, and what their hope is to start the diet so that they can taper medicine or reduce anti-seizure medication burden, in which case that is what we're using the diet for, and we might start lowering medicine very quickly. But that patient is already seizure-free. And in that case, we'll usually have them also stop driving just to make sure that it's safe to do so in that short period of time. But often driving can be a major motivator.
Next question is it true that if a patient weans too soon from the keto diet and then tries to return to that diet, it's possible that the patient could never return to the same level of seizure control? Interesting. Has your clinical or research experience shown this to be true? It's actually, to my knowledge, never really been studied in that way. We have definitely had some children that after 2 years on the diet, which is typically the time we will try, we'll wean the diet and the seizures can come back. Usually we put them back on the diet and it usually controls them. Sometimes families still want to come off the diet and switch to a medicine or continue the medicine. But most of the time, if we go back on the diet, the seizure control is resumed. We sort of looked at this in a different way by looking at children who tried the diet for a second time, sometimes years later. We called it sort of our keto redo study, where sometimes years later we tried it again. And often what happens the first time is what happens the second time, good and bad. So usually I would tell families if it worked before and we try it again later, sometimes even in adulthood, it'll often work again later on. So I don't think I would necessarily be as worried about this question per se, that weaning the diet is going to lead to seizures coming back and then not being controlled again. It's certainly possible, but it's, I think, pretty rare.
We do know that to be the case sometimes for anti-seizure medicines, though, that sometimes if someone is controlled but tries to wean, at times, if they try to go back on that same dose again, we don't know why it's the case, but they may not be able to return to that same level of control. So that has been shown to be the case in some instances, but you're right. I don't know particularly that it's been studied with the diet.
Okay. Next question. Have you noticed any correlation between starting diet therapy sooner in patients to the time they gain seizure freedom? Interesting too. Yeah, I mean, in general, study after study, at least in pediatrics, would suggest that the lower the number of prior anti-seizure drugs, the better they're likely to do in terms of control on the diet. I'm not sure necessarily seizure freedom per se, but the time to improvement from day one of the diet till when the seizures improve, that doesn't seem to matter. So we've had children who have had uncontrolled seizures for years, have maybe an indication like we talked about in our lectures that the diet is really good for, go on the diet and the seizures can sometimes stop right away. So I don't think that necessarily that influences the time to improvement, but it does seem in the big picture to be more likely to lead to better outcomes if you try it sooner.
I think for adults, it's still considered almost a treatment of last resort in a lot of cases. So in many of the studies that I referenced, it's often used after the 6th or 7th or 8th anti-seizure medicine, and maybe after a vagus nerve stimulator or epilepsy surgery or responsive neurostimulator. So I don't think we have a lot of information yet about what would happen if you started the diet earlier. We certainly do have some individual patients that choose the diet earlier in their management or come to us early, but often it is after they have been through many medications and other treatments and then learn about the diet and come to clinic. So I don't think we yet have that much information with regards to adults.
Okay. Next question, is the medium chain triglyceride MCT oil diet or the modified MCT diet something a patient could naturally progress to instead of the classic ketogenic diet, as long as this diet keeps them seizure-free? Yes. Quick answer. I think one thing we're realizing is that being flexible between the diets is absolutely appropriate. Between the modified Atkins diet and the ketogenic diet, we certainly have patients go both directions. We have definitely had families that have gone more towards an MCT diet over time based on either tolerability or maybe improvements in the lipid profile, and it seems to be generally equal. Our most recent pediatric consensus guideline, we really, I think, try to hammer that point home that the diets are more alike than different. And so, going from one diet to another based on, patient preference, child preference, family situations is definitely appropriate.
And I think, with the medium chain triglyceride oil, it can be incorporated with any of the diets, which is really nice and gives you that flexibility, particularly if you are just having difficulty with maintaining ketosis, even though you know that you're following all the rules, doing everything with the diet. It also can help sometimes with constipation as well. That's another time that the medium chain triglyceride oil can be helpful. We've also looked at it particularly with targeting catamenial epilepsy. So if you want to boost ketosis during a particular time of the month or times when you can anticipate the seizures might be worse, that's another time that medium chain triglyceride oil can be particularly helpful. But you can always add that to any of the other diets and not necessarily have to transition to a classic ketogenic diet, for instance.
Very sophisticated question next. Someone asked, does the ketogenic diet work to change gene expression in some way? And then sort of part two, will it keep working? Theoretically, if you change gene expression, will it keep working after you stop the diet? So it gets to the sort of the big question that I think a lot of us wonder, struggle with, and some of us are studying about whether the diet is truly anti-epileptogenic, not just an anti-convulsant therapy. Does the diet perhaps lead to an improvement in their epilepsy, the underlying epilepsy, not just controlling the seizures while they're on it? The second part of the question is kind of relevant because we've seen that where children stop the diet, they're seizure-free. The natural history otherwise of their epilepsy would never predict that would happen without an active therapy, and yet they come off the diet and sometimes all of their medicines and remain seizure-free indefinitely. And that strongly would suggest that the diet is having a beneficial effect on their underlying epilepsy. How that happens, well, first of all, if that happens is still debated, but how that happens, I think, is not completely clear. Maybe it's gene expression. I don't think we know for sure. Is it doing, again, something on a neuronal level? Is it sort of improving your mitochondrial function in a way that will stay permanent? Unclear. Why? How does it happen? I think is unclear. But also, if it really happens, is still not completely sure.
I see the next question is about adults, so let me take a look. So for adults who had success controlling seizures with one medication, not refractory epilepsy, but the side effects made that medication intolerable, depression, unreasonable tiredness, is diet therapy an option? So in that case, we do see patients where medication has been tried. It may even be successful, but the patient is having side effects. So diet therapy is absolutely an option. What we typically will counsel patients about is that it really hasn't been studied extensively as monotherapy. You heard about the Absence trial that's currently ongoing in children. There isn't a similar trial ongoing in adults, but certainly there are adults with absence seizures. So I think that those findings can be applicable to adults as well. And so when a patient has that interest, what I'll explain is that we just don't have as much data to support the use of the diet as monotherapy, but certainly we could begin by incorporating the diet and seeing if we can lower the dose of the anti-seizure medicine that is causing the side effects. I also am an epileptologist who treats patients with anti-seizure medicine. So often I will start the diet and then maybe talk about incorporating a different medicine or other, therapies as well to try and see if we can tackle the problem in lots of different ways. And so that's usually how I would handle that.
Okay. Question for pediatrics. For children, what's the percent of effectiveness to reducing atonic seizure frequency? So yeah, so it has been looked at in quite a long time, but in some of the earliest studies of the ketogenic diet, they looked at seizure type, not just the seizure etiology or syndrome. And if you go back to some of the earliest studies of the diet, it seemed to work very well for what we call the generalized epilepsy. So myoclonic seizures, absence type seizures, as we've talked about already, but also atonic seizures. These, for people not familiar, these are seizures where the child will have a quick drop, sometimes with an injury, unfortunately, when that happens. The diet can be very effective for atonic seizures. In fact, probably, going back again 100 years, when they didn't have a lot of seizure medications that were good for atonic seizures, some of the earliest reports would describe it as one of the best therapies for atonic seizures. We do have now some therapies, clobazam, vagus nerve stimulation, for example, that can be pretty helpful for atonic seizures, but the diet is still very potent. And most of the syndromes where atonic seizures are part of that condition, Lennox-Gastaut syndrome, a condition called epilepsy with myoclonic atonic seizures, or DOSA syndrome, the diet is extremely effective. So it's a good question that we haven't looked at in a while, looking at the seizure types. I think nowadays we're much more focused on the syndromes. But yeah, I think atonic seizures do definitely respond very well to ketogenic diet therapy. And then kind of the flip side, focal seizures, maybe not as potent in effect, but we do have children with focal seizures, maybe sometimes even as part of a larger syndrome, that can see some benefit for those too as well. But yeah, atonics very much. Okay, this is probably true for both peds and adults. A question about pediatrics, but I think it applies to adults too. How should a child proceed with a ketogenic diet if they have a high cholesterol, again, assuming at baseline, or eat dairy, for instance? So dairy is obviously fine on the ketogenic diet. There's no specific issues that my dietitian has not been able to tackle. We have had families that have been vegan, in fact, and have been successful on a ketogenic diet. So having, not an aversion to dairy or eating dairy, either way is fine. The first part of the question, though, is definitely important. We do sometimes see children where during our baseline lab screening, their lipid profile is abnormal. Usually the first question is why? Is there some familial hypercholesterolemia? Are they on a medication that could cause high cholesterol? One of the most famous is carbamazepine that can do that. Or is there something else going on that we need to investigate first? If they're slightly elevated, we still will usually proceed with the diet, but we might use a lower ketogenic ratio. We might incorporate more MCT oil, which can be a little bit kinder on the lipid profile. We may do some of those modifications to their diet to make sure that they're safe on it. There was a really nice study that was done out of the team in Canada, where they looked at children who had high cholesterol like this, went on a ketogenic diet, anything their cholesterol values decreased. Surprising on the diet. So it's not necessarily a contraindication. It might be just something that we adapt for. In adults maybe. But.
Yeah, in adults, we do we monitor cholesterol frequently. We tend to see that when patients first start the diet, we tend to see that the cholesterol levels go up and then they start to trend down over time. However, the longer we've been watching them, we see them start to sometimes go back up again. And as Dr. Kossoff was saying, it can be familial. One of the things I mentioned Dr. McDonald is looking at is not just the HDL, the LDL, the total cholesterol, but actually the particle size of the LDL particles, because that helps predict whether or not the patients are at higher risk of future cardiovascular disease, because some of those numbers don't tell the whole story. And so this is part of the research that's really ongoing. Some of the things that we do recommend for patients who seem to have elevated cholesterol that's sustained long-term is, you mentioned dairy, switching out some of the products like the heavy whipping cream for things like olive oil, avocado oil, and some of those can actually help with reduction in those lipid values. Exercise is always excellent. And so there are some other modifications that can be made. And then in rare circumstances, for instance, if someone does have a familial predisposition, then they might have to be on lipid-lowering medications if the diet is otherwise very effective, just to make sure that the diet is not adding additional risk that we really don't want those patients to have long-term. And so that's really how we manage that in adults. And then I do see another question that's asking about managing weight gain, which of course in children is usually desirable. So I'm thinking that might be a question that's more about adult patients, except I guess it could go either way. There are instances, I know I mentioned that the diet has become very popular for weight loss in adults, and that's primarily because the ketone bodies themselves tend to suppress appetite. And so that's actually the mechanism why the diet is very, popular, particularly for weight loss. However, in the instance where what we call carb creep happens, where more carbohydrates are kind of integrated into the diet than people realize, or perhaps they have kind of stopped really counting the carbohydrates as closely. This tends to happen more with the modified Atkins diet than it does with the classic ketogenic diet, because with the classic diet, you're weighing your foods, you know exactly what the carbohydrates are that you're taking in. The modified diets, at least in our adult population, what I hear from patients sometimes is they sort of estimate, or they kind of look at food labels, or they sort of know how many carbs there are in berries and things. And so after a while, they stop really strictly counting, and that can kind of result in increasing the carbs over time. And when you're doing that, but you're still eating all the fat that you're accustomed to eating, that can result in increased caloric intake and increase in weight. And so those are some of the things that we take a look at if patients are noticing weight gain, or perhaps if they had a secondary goal of losing weight and that's not happening. And in that case, that's where the dietitian, the nutritionist, is just absolutely vital, because what they can do is they can actually do a food recall or a food record and look at what the patient is consuming, and that will give them a better idea of the macronutrient composition of their diet, and they can kind of fine tune the suggestions on how to help with the weight loss.
There's a question asked, if ketones are capped at 5 millimoles by the ketogenic diet team in the hospital, does it render the diet ineffective for children who need to be on higher ketones? Possibly. So yeah, it kind of gets to the bigger question about ketones and checking ketones. At least in pediatrics, it's about 50-50 between most keto centers, whether we check urine ketones or check blood ketones. Children with GLUT1 deficiency, specifically a form of metabolic condition where epilepsy can be part of it, and they do well on the ketogenic diet, traditionally those children always check blood ketones, but otherwise it's about 50-50 among pediatric centers. And so, and that really is done because we don't know for sure how important ketones are. We know they're a marker that your body has made the metabolic shift towards burning fats and using ketones as an energy source. But it's sort of in a way like a drug level, right? Where for some children, a high drug level is important. For other children, it really doesn't matter. But the drug is helpful. It's not always a direct correlation. In this particular case, maybe, if the child seems to need higher ketones above 5, it may be necessary. And it's something that usually can be done carefully. You can get children to higher blood ketone levels. Most children on the ketogenic diet, if you check blood ketones, are sort of between 3 to 5 or sometimes 3 to 6 millimoles. So, if the center is really trying to keep things below 5 in terms of side effects, you could try to gradually go up, with the dietitian, with the neurologist following carefully for any side effects. There's another question for pediatrics. It was mentioned in our talk that children stay on the diet, for about 2 years. Is this when you expect them to outgrow their seizure activity? Sometimes yes. So it's kind of an old tradition that goes back to what we do in anti-seizure medications for children that sometimes have time-limited epilepsy syndromes. There are some epilepsy syndromes that children can outgrow. There are, in fact, sometimes some very severe epilepsy syndromes. One of the ones I mentioned a couple times today, epilepsy with myoclonic atonic seizures, where the children can outgrow their epilepsy, even though they're having frequent drop seizures. You wouldn't expect that, but they can. And so we do know children can outgrow their seizures. And so sometimes we will try to wean the therapy that they're on and see if it's maybe no longer necessary, that the epilepsy has been outgrown. It's always a case-by-case decision. In fact, sometimes even at 1 year, we may raise that question with the family of maybe the diet has sort of, in a way, we'll say, like, outlived its usefulness, that they've sort of reached a plateau in seizure activity. We will wean the diet in children even at 2 years if they're still having seizures, because we may say, look, we don't think we're getting any additional benefit. Maybe over the last 12 months, the seizures have been very stable. Let's at least take you off and see what happens. And as was sort of an earlier question, we can always go back on if you need it. But in many cases, you wean the diet. In fact, about 80% of the time, you can wean the diet and the seizures don't get any worse. So, knowing that the diet has long-term side effects, we don't want to keep children on it longer than they have to be. A little different than perhaps adults, but in children, we will at least raise that question about that maybe we can try to take them off. Obviously, case by case. Okay, this is maybe sort of true for adults too, although maybe a modified Atkins diet. There's a question raised about sort of fine tuning, asking how often do we see adjustments being made to various ratios for children. So we did a study of this a few years back, looking at what we call fine tuning the diet. There's almost infinite numbers of ways you can manipulate the components of the ketogenic diet. In some ways different than medicines, right? Where you could go up in the dose or go to 3 times a day, or maybe an extended release preparation. And in the ketogenic diet, you can change the ratio, you can change the calories, you can change like what the meal's fat sources look like, how many times a day you're doing it. We do a lot of that. And there is some science now behind some of those adjustments. And in fact, ratio changes for the classic ketogenic diet are probably the most effective of the diet changes that you can make. So if we have a child who's perhaps on a 3-to-1 ratio and they're improved, but maybe not as improved as we would like, we might go up in the ratio. And if they're having a side effect, sort of a different reason to lower, we may lower the ratio, in fact, to try to improve that.
And I think in adults, when we think about ratios, we also think about net carbohydrates with the modified Atkins diet. So we may start with the modified Atkins diet and adjust the net carbohydrates. We may, as we talked about earlier, incorporate medium chain triglyceride oil. We may incorporate some kind of intermittent fasting as well. And so that's another thing that can be done instead of adding more meals throughout the day. We might shorten the intervals of when the patient is having meals. So yes, you can do, as Dr. Kossoff was saying, an infinite number of kind of changes to the diet to basically incorporate what fits for that individual.
Okay. Next question was, with the modified Atkins diet, have you found patients to lose or gain weight? Is there an increase or decrease in energy levels? So, at least in pediatrics, as was sort of mentioned by Dr. Cervenka, we don't generally want our children to lose weight unless maybe they're overweight to start. We want them to have a slow weight gain that's appropriate. And in most children on modified Atkins diet, or actually any diet for that matter, usually we do see sort of a nice weight gain over time. The energy levels, sort of, what are the child doing in terms of their activity level, usually is great. Maybe the first few days as they start the diet, they might be a little sleepy, a little sluggish. That's part of why we bring them into the hospital to monitor that. But usually very quickly, they perk up and are back to their energy level. If anything, sometimes they're even better as the seizures get under control.
With the modified Atkins diet in adults, they typically will lose weight initially starting the diets, and then their weight will eventually plateau. As I mentioned, if there's that carb creep phenomenon that happens, or I guess you could also say protein creep, because sometimes patients will focus on minimizing the carbohydrate intake, getting very, very good at meeting those targets of limiting carbohydrates. But when they think about eating fat and protein, they may tend to eat more protein, or maybe fatty protein, and just be eating a lot of that. and not producing ketones, and also not necessarily losing weight in that case, or having the benefits of appetite suppression. And so in that case, they may kind of be weight neutral at that point. So we see initial weight loss, and then we see sort of a plateau over time in those cases. Often they do have an improvement in energy. It's fairly rare for an adult on a modified Atkins diet to have their ketone levels go so high that actually suppresses their energy levels. So if anything, we do see improvement in energy levels.
Looks like the last question that has come through, is there any research on the use of exogenous ketones in humans? Yeah, it's a hot topic in our community, especially for trying to increase ketone levels in children and adults, for that matter, who are on a ketogenic diet therapy. Is there a way to boost that ketosis beyond sort of the foods that they eat? And then the flip side of using, again, an exogenous ketone, a ketone you would drink or eat, would be that maybe you could cut back on sort of the foods that you're eating in terms of the fat content, and sort of be back to sort of what you were eating before by using a ketone supplement. There is emerging data, not really yet in children with epilepsy, more in sort of healthy volunteers and some other populations, that suggests you can definitely boost your ketones, although it may only last for a couple hours, and then it does seem to wear off. We've tried it anecdotally in some of our patients with epilepsy, where again, we're just not getting ketones as high as we would like. And we've had sometimes temporary mixed benefits from it. But it is a very important topic, and a lot of researchers are looking at that, not only as a way to supplement a ketogenic diet, but maybe, as a substitute for it.
I did see a study come out just this month looking at fasting, ketogenic diet, and exogenous ketones, and comparing the beta hydroxybutyrate, which is the blood ketone level, in all three of those instances, combined with exercise, in healthy control patients, so not individuals who have epilepsy necessarily, just to see what happens with the ketone levels over time. And in a 24-hour period, the diet, the ketogenic diet, and this was a less rigorous diet than a classic ketogenic diet, and fasting were very similar. And as Dr. Kossoff was saying, the exogenous ketones, or at least one supplement, really increased the ketones, but then they started to trend down over time. You really can't sustain that same 24 hours of high ketone levels with the exogenous ketones. So the major limitation at this point is having to take them over and over again. And the concern with epilepsy is that you really want the therapy to be pretty consistent over that time frame, and you don't want those levels to be dipping down very quickly. So I think it's promising, but I think there's still more work to be done.
Okay, with that, it looks like we've sort of reached the end of our questions. Thank you all for your very kind attention, and have a nice afternoon.
Thank you very much.